Representative Ruiz, and thank you to the Congressional Hispanic Caucus Institute for having this panel and inviting me. So I'll just be brief. First of all, as a director of a National Institutes of Health Institute, I can say categorically that we are committed to addressing issues of minority health and health disparities. Perhaps the best example of that is that this institute exists. It started as an office under the Health and Human Services Secretary Sullivan, and this was then advanced to a center during the latter part of the Clinton administration. And as a result of the Affordable Care Act in 2010, it was actually made an institute. Now, at the National Institutes of Health, these are categories that matter. An institute has granting authority, has a slightly higher budget, or the budget may not be the direct issue. But we have a seat at the table with Dr. Collins and the other 26 institute and center directors to address these issues. That is my role. I'm new on the job. I started a little over a month ago, and I moved here from California, where I was at University of California, San Francisco for 37 years. I'm also a general internist and a primary care physician, which I have put on the side in doing this job. But our mission is to address these two related but not mutually overlapping or exclusive areas of minority health and health disparities. And in minority health, we are focused on what is the health of the U.S. population by the racial ethnic categories that we currently use from the U.S. Census. And that, of course, includes Latinos, which technically are a mixed group, not a particularly separate race. We're also very interested and focused on socioeconomic status as a second important pillar of what leads to advancement in science in these areas. And we have included rural poor as a population target as well. The science of discovery is what NIH is about. And our role in this sort of not focus on one organ system or one disease or a set of diseases is to look at what causes, what leads to these different health disparities, or what mechanisms lead to differences or advantages or disadvantages among different minority groups. And identifying these etiologic mechanisms is the sort of the underpinning of what we will work at. And my charge will also be to figure out how to collaborate and leverage the other institutes, which have much bigger mandates and much bigger budgets, so that we can address this across the entire NIH. And these will include issues around the social determinants and individual behavior. After all, example of excess obesity, for example, is related not just to what an individual does, but also what kind of food access one has in their neighborhoods. What can they afford, for example. Healthcare access is a major issue. How do our populations interact with the healthcare system? Representative Ruiz, Dr. Ruiz mentioned the increased mortality from breast cancer among Latino women who are diagnosed. And there are data that indicate that this is related to lack of access to primary care physicians and lack of routine mammography for the women who've already been diagnosed with early breast cancer and presumably cured and should be cured, but they have a high risk of recurrence. They die more often because they're not getting detected earlier. And finally, the whole category of biology and genetics. There's a fascinating set of stories to be said about Latinos that could be figured out from the genetics of the admixture, and this is one component to further evaluate in our understanding of health disparities. We will then also look at issues of developing and implementing and evaluating interventions that work. We're not about massive studies, but we need to find the right ones that have been. Let me finish by just saying that the Latino population, lots has been discussed. Maybe it'll come out in our conversation. We are a very heterogeneous group. We are a mixture of immigration over 500 years. There's European mixture, there's African mixture brought in from Africa, and the indigenous people of the Americas. This is actually a great opportunity to learn about mechanisms in this population. It is one of the unique populations in the globe that have experienced this over this period of time. And I believe that understanding what leads to outcomes in our population will have lessons for all people in the U.S. So, thank you.
Thank you very much. Now, Alejandro.
Great. Good morning, everybody. Thank you, Congressman Ruiz, for the invitation. Thanks to the Congressional Hispanic Caucus Institute for the invitation as well. We at the Desert Healthcare District are very proud to serve the residents of the Coachella Valley since 1947. Through our grants program, we have provided resources and support to local community-based organizations which target low-income and underserved community residents utilizing the community health worker model, or better known as the promotora model. The community health worker model is based on the recruitment, empowerment, and employment of local community leaders who face the same health disparities as the people they serve. This sharing of the same cultural traditions and language allows these community health workers to reach and connect with community residents that traditional outreach or marketing methods do not reach. Two perfect examples of this are our partnership with the California Endowment for the enrollment under the Affordable Care Act, where we subcontracted with 4 local organizations that utilized the community health worker model, the promotora model, and then went into the same trailer parks that Congressman Ruiz was talking about to enroll community residents that qualify for the Affordable Care Act. But they also went beyond that, not only enrolling them, but also providing educational resources so they knew exactly what benefits and how to actually make a neighborhood educational center, which is a nonprofit based out of the Riverside and San Bernardino counties there in California. And they also use the promotora model to be agents of change while including them in the planning, implementation, and evaluation of programs and services, provides us with immediate knowledge into the struggles and barriers our communities face. Thus allowing us to allocate resources and support to address these issues in a culturally appropriate and sensitive manner.
And Dr. Vaniz.
Thank you for this opportunity. I just wanted to build upon a few of your statements earlier. First, the statistics were really eye-opening, and I think they're really a call to action. That's what this session is about. Second, although I'm a healthcare insurance plan executive, I'm also a physician, and really my focus every day in what I do is about taking care of patients and being a physician. And third, I knew I wanted to be a physician since I was 3 years old. But all jokes aside, Latinos are, we know, disproportionately affected by chronic diseases: diabetes, heart disease, hypertension, end-stage renal disease. And CareMore's model, the way that CareMore was designed, is really to address these chronic diseases. CareMore started as a medical group by physicians, and the focus of CareMore has always been on caring for patients, engaging patients, removing barriers, and matching care desired with care received. And so I want to take a moment just to explain what CareMore is, because CareMore's a health insurance plan, and it has which have culturally sensitive material. They have health, social, and fitness events, again, which are readily accessible to that population. And the success is phenomenal. That our chronic disease management programs, we've been able to reduce amputations by 60%. We've been able to reduce the progression of end-stage renal disease significantly. We have fewer hospitalizations. Our focus is really on preventing complications before they happen. And we do that by engaging patients. So I mentioned about the staff speaking the language. We also involve the family. So that's a very important part of the Latino culture. We're aware of that. Connecting communities, treating chronic diseases, preventing complications before they happen. I think that's really one-on-one, comprehensive, holistic, face-to-face care between the patients, the community, and the providers. And that's how we can really continue to address these disparities.
Good morning. On behalf of Walgreens, I'd like to thank Congressman Ruiz and the Congressional Hispanic Caucus Institute for leading this conversation on healthcare issues impacting the Latino community. Thank you for the opportunity to participate in today's panel. I've heard some great stuff so far. It really gets me excited. For more than 100 years, if you don't know, Walgreens is over 100 years old. We've been a cornerstone of health in the urban community. Our first store was in the south side of Chicago. And ever since then, now we've grown to 8,200 locations. Our core purpose is to champion everyone's right to be happy and healthy. We fulfill that purpose in part by providing the most convenient access to healthcare services and trusted clinicians, providers in thousands of communities across the U.S. Walgreens and our team of pharmacists and nurse practitioners are located within 3 miles of 78% of the Latino community and 75% of the African American community, and that's by design. Additionally, half of our stores serve medically underserved populations who need greater access to affordable care. As we know, access, which is a word that's been used quite a bit today, or lack of it, remains a critical barrier contributing to health disparities, especially in medically underserved communities. Access challenges can impact health screening rates, vaccination rates, and utilization of other services that can help prevent or provide early detection of disease and a number of chronic conditions. For many people in underserved communities, Walgreens is the store on the corner where the pharmacist serves as the frontline healthcare provider. And some of us call it La Farmacia, and some of us call it La Walgreens. Walgreens bridges the gap to care to the services we provide in our more than 8,200 locations and collaborative relationships with other healthcare providers to help manage and coordinate patient care. Pharmacists are a critical part of patients' care team and commonly provide medication therapy consultations, disease